Hi, nice to meet you. I'm Ken, Seoul, Korea. Today's my topic is when to perform combined surgery for cervical myelopathy. This is my patient, male, 76-year-old, showed typically a cervical myelopathy symptom. He showed severe mixed OPLL and canal occupying ratio about 80% C4-5 segment, and showed K-line negative. On which surgical option do you choose? Which level? Maybe it's ACCF, laminoplasty, or PDF, or AP combined fusion surgery you will choose. Today's content is like this. As you know, anterior and posterior surgery showed many advantages and disadvantages. Anterior surgery have advantage direct compression, better recovery rate, valuable for kyphotic alignment, and huge anterior mass, and considered relatively safe 1 or 2 segment. Conversely, posterior is valuable for multi-level congenital stenosis and considered low OP-related complication and better tolerable in old age and better stability. I analyzed the inevitable situation for anterior surgery. First situation is kyphotic alignment. 2003, Sudaido showed the important risk factor for laminoplasty. If a patient showed local kyphosis more than 13 degrees, laminoplasty is contraindicated. In 1999, Yamazaki also showed similar result. More than local kyphosis 10 degrees is contraindicated, and maximum OPLL thickness is 7 or more millimeter. Those situation is contraindicated for laminoplasty. Second, in inevitable situation for anterior surgery is cervical sagittal alignment. Also, risk factors of laminoplasty. 2017, Sakai et al. Showed, and 2016 also, Sakai showed sagittal vertical axis more than 40 millimeter is a risk factor for laminoplasty. Also, 75-year-old, more than 75-year-old is also contraindicated for laminoplasty. Third, inevitable situation for anterior surgery, canal occupying ratio. 2013, Fujimori showed that more than 50% of canal occupying ratio showed significantly higher recovery rate in anterior surgery than posterior surgery. They reported that anterior decompression fusion is generally recommended for with the occupying ratio more than 60%. And for severe occupying ratio and most mobile segment, HCDF is typically a middle and lower level recommended, and sometimes in case of combined laminoplasty. Fourth, in inevitable situation, OPLL progression. 2010, Murakami showed the OPLL progression cases. He reported that progression was marked between 4 and 8 years after first examination. So, in case of possibility of OPLL progression, severe OPLL cases, we should choose the anterior surgery. 5 situation is heel-shaped OPLL. 2007, Iwasaki showed this result. Patient with heel-shaped OPLL showed significantly lower recovery rate than plateau-shaped OPLL. So in case of heel-shaped OPLL, we should consider the anterior surgery. This is my patient, male, 59. He showed gait disturbance and clumsiness, voiding difficulty. In CT scan, severe huge OPLL mixed type. C4-5 and C5-6, you can see the huge OPLL mass. Sagittal alignment seems to be good, but the maximal canal occupying ratio more than 70% at 4-5 and 5-6 segment. I wonder which surgery is best. First is posterior approach only, second anterior approach only, and AP combined surgery can be considered. I choose anterior posterior combined operation. First stage, posterior aminotomy fusion performed, and 3 days later, second stage, anterior cervical corpectomy fusion at C5 segment was performed. And post of 3 years, posterior first, anterior second were maintained. I choose anterior surgery for this patient, maximal canal occupying ratio more than 70%. In some cases, posterior surgery only is possible, but I think more than 50 or 60% canal occupying ratio sometimes make the neurology deterioration. So in those cases, I think that anterior surgery, combined anterior surgery is considered also. Inevitable situation for posterior surgery, I found this 4 categories. First is multi-level congenital stenosis, and second is better stability and higher fusion rate is necessary. And in case of cervical deformity correction, we should consider posterior surgery. And sometimes we need maintenance of cervical alignment using posterior surgery. In this case, male 63 patient, both hand clumsiness and right upper extremities, radicular pain and posterior neck pain. He showed severe cold compression at C5-7 with a high signal change. And sagittal vertical axis 47 millimeter, more than 40 millimeters, so imbalanced, and showed congenital stenosis. Impression is mild radiculopathy used with the sagittal imbalance. I choose the single stage HDF 5-7 and also PDF surgery combined. I did anterior surgery because he showed right upper extremity radicular pain. And sometimes posterior only surgery showed severe postoperative radicular pain in case of severe foraminal stenosis. So in case of in this patient, upper radicular pain, also sagittal imbalance, lower segment anterior surgery combined will be considered. As you know, best indicator for anterior or posterior surgery is K-line. 2008, Fujiyoshi showed it is a useful prognostic factor for kyphosis and Hughes anterior mass. However, K-line negative patient, laminoplasty contraindicated. If then, which option do you choose? I think the alternative first option is for patient with K-line negative patient. First is 2016, Sang-Hoon Lee et al. Showed 540-degree realigned fusion technique. Posterior decompression first and later staged operation and single level operation like this and posterior fusion confirmed. So he get the K-line negative to K-line positive. Second option is for K-line negative patient. As you know, it recently popularized 2018, Dong-Hoon Lee et al. Introduced vertebral body sliding osteotomy. Using this technique, minimize the complication associated with OPLL and sagittal vertical axis or cervical kyphosis correction and stabilize the posterior fusion technique. Advantage of the IP combined operation like this are safe, circumpression, direct decompression, alignment correction can be done, and better stabilization, and we can choose a staged or same-day operation. This advantage is associated with longer operation time. In the literature, AP combined surgery is considered safe and effective surgery, and the single-stage surgery is more favorable in the literature. However, still few evidence for AP combined operation. This patient that I showed at the beginning, a male 76-year-old patient, showed typical myelopathy symptom, severe mixed OPLL like this, and canal occupying ratio about 80%, especially C4-5, and K9 negative. Which surgical option do you choose? Which level do you choose? What is your choice? I choose for safety laminoplasty first, and for efficacy, I performed one segment HDF and post-op 2 years well maintained. I used the safest two options, two-staged laminoplasty and staged HDF one segment. I get the K9 negative to positive. Anterior posterior combined operation surgery have many advantages, both anterior and posterior surgery. If minimize anterior posterior fusion segment, you can minimize complication and maximize outcome. Thank you.